And go ahead.
So, next slide. We've talked about chronic hypertension, and we all know it's either hypertension prior to pregnancy that the patient's been told about, or 140/90 or greater prior to 20 weeks during pregnancy. Next slide. Chronic hypertension is associated with significant morbidity and mortality. 20 to 50% of patients with chronic hypertension develop preeclampsia, and upward of 75% with end-stage renal disease develop preeclampsia. Outcomes are worse for hypertension and preeclampsia than either hypertension or preeclampsia. It is recommended by the U.S. Preventive Task Force that aspirin, 81 milligrams after 12 weeks, be given to all patients with chronic hypertension to reduce their risk of preeclampsia. Now, I will just tell you, we debate this at MUSC as to whether or not we should start it earlier, or if we should give 150 milligrams, because that's what the Europeans give. But I still give 81 milligrams. I just tend to start it a little earlier than 12 weeks. But this is the recommendation that ACOG endorses. Next paragraph, or next slide. It's important when you're looking at hypertension in pregnancy that we understand the changes that we see in pregnancy. Starting about 10 to 12 weeks, our blood pressure normally drops. And then about 28 to 32 weeks, it starts going back up. And I will tell you, if I don't see that little drop in blood pressure, it makes me think that this is one of the ladies that will develop preeclampsia. But that's a Donna-ism. Next slide. When we're looking at changes in our labs and stuff, we have to remember that creatinine usually drops, creatinine clearance goes up, and if we have no protein, we usually don't develop protein during pregnancy. But if you start with some baseline protein, then you usually increase your protein later in pregnancy. Uric acid is filtered and therefore it goes down. Liver enzymes stay the same, platelets stay the same, and the CBC usually decreases in the second trimester because the plasma volume has exceeded the red blood cell volume. So you get slightly a dilutional anemia. Like if you start at 12 and 36, you'll probably at 28 weeks be like 11 and 33. It's not a huge dilution, but there is some mild dilution. Next paragraph, or next slide. So the diagnosis of superimposed preeclampsia, it is not easy. We deal with this day in and day out, and often it is a diagnosis of exclusion. So from here forward, you're going to get a lot of Donna-isms, and it's not based, I mean, I read a few different articles, review articles, some books, and it's really, they give you no good specifics about how you diagnose superimposed preeclampsia. Next slide. So the first thing I look at is the blood pressure. Okay, if my blood pressure starts going up, it's usually going to start going up around 26 to 28 weeks. We are to start medicine at 160 over 110, but to be honest, I usually bump my blood pressure medicine at once I get 150 over 90. So if I got a chronic hypertensive that's on no medication, when I get into this range, I start medication. I usually start labetalol, and you may ask me why. Remember, if the, as long as the patient doesn't have asthma, I don't. Nifedipine tends to work better than labetalol, but the issue with not nifedipine is one of the side effects is a headache. So that's why I start with labetalol. And I usually max out on that drug, which is 2,400 milligrams divided into 3 doses. If they're on a low dose, say 200 milligrams of labetalol twice a day, and they've been well controlled, then I start escalating that medication. Now, if they're already at 800 TID of labetalol, then I will add a second drug, but I usually set parameters for myself to max out on one drug if I started or they're on a low dose, or I max out on 2 drugs before I consider a hospitalization. I encourage these patients to check their blood pressure at home. I think it's essential to see patients who are getting escalating blood pressures often. And by often, I mean at least twice a week, every 2 to 3 days. Warn the patient regarding symptoms and tell them if they get symptoms, then they should call you or just come in. When I start escalating drugs, I also give steroids, and I also start to consider antenatal testing. Next slide. So we've talked about blood pressure. Now let's talk about protein, because preeclampsia is hypertension and proteinuria. So if you recall, I told you if the patient had no baseline proteinuria, I do a PC ratio. And I can use, and then if they start to develop proteinuria at 26, 28, 30 weeks, then I can use a PC ratio reliably and determine whether or not it went up. But if they have baseline proteinuria, then I collect a 24-hour protein, and I get a creatinine clearance also. So in pregnancy, protein generally increases. So if they're coming in the first trimester at 2 plus, then you usually by 20, 22 weeks are dipping 2 plus, and then by 26, 28 weeks, you're dipping 3 plus. So that can be the normal progression of the changes in creatinine clearance because it goes up 40%. So if the protein is increasing and the creatinine clearance is increasing, I call this normal physiology of pregnancy. But if protein is increasing and creatinine clearance is decreasing, then that is superimposed preeclampsia. Next slide. The other labs that I look at are creatinine. We all know that creatinine is usually less than 0.8 in pregnancy. Often it's 0.4, 0.5, 0.6. It is rare that you see a patient with 0.8 or greater. So if their creatinine is increasing, then I think preeclampsia. If their platelets are decreasing, I think preeclampsia. And obviously, if their LFTs are increasing, I think preeclampsia. Now, some people argue that uric acid should be added to the labs of preeclampsia. I don't have any problems if you order it, but to me, it's not helpful because it does the same thing for me that creatinine does. Because as the creatinine goes up, your uric acid's going to go up too. And so when your uric acid gets above, and again, the cutoff, it depends on where you read and what you read, is anywhere from about 5.5 to 6.2. If uric acid is above those levels, think preeclampsia. Next slide. So obviously, I also tell patients at every visit, if they develop an uncontrolled headache, or if they develops a headache, well, let me back up. I usually ask a woman, do you have headaches? Oh yeah, doctor, I usually have a headache at least once a week. So I tell them, if you get something outside of your normal headache, or if you get a headache that doesn't respond to your usual methods like Tylenol, a nap, whatever, then you should call us. Blurred vision or lights in front of your eyes, or beside your eyes. In fact, one time I had a patient tell me it was like a freight train coming down the track beside her eyes. If they develop pulmonary edema, and of course, they're not going to call you and say, doctor, I got pulmonary edema, but they will call you and say, I'm short of breath. And obviously, if they got right upper quadrant pain. The other two symptoms that I want you to be very careful with, even if the patient is on the floor, is vaginal bleeding and or contractions, because both of these can be signs and symptoms of an abruption. And all of these patients are at increased risk for an abruption. Next slide. So when do I consider delivering these individuals who I think has superimposed preeclampsia? So first of all, if they get to 37 and 0.7 weeks, I deliver them, okay? Please do not let the 39-week rule mess you up here. 39 weeks is an elective delivery. This is not an elective delivery. It's being done for maternal and fetal indications. Second, if I can't get their blood pressure controlled, okay, like if they hadn't had medicine or a very low dose, I max out one drug. If they've been on a high dose of one drug, I max out the second drug, okay? And if I can't control hypertension then I consider it's time to deliver the patient. Also, worsening renal function. If it's going to 0.9, 1.0, then I'm going to consider delivery. Obviously, if she has help, low platelets, elevated liver enzymes, hemolysis, then we should deliver, and we should also deliver them for symptoms. It's not always an easy decision to make, but I think you should give yourself a very clear-cut parameters so you don't get down a rabbit hole and you're on 4 medications and the patient's still getting sick. I think that's my last slide. Yes. Okay. Anybody with questions? And again,